This film is intended for eye surgeons for training and education purposes. Today's presentation is going to be about the capsular bag stabilizing devices. The main focus is going to be about capsule tension ring. The CTR is a simple device but has been a game changer as far as cataract surgery is concerned. Simply put, it has saved many eyes from losing their capsular bags over the years. The CTR performs two distinct functions. It supports localized zonular dehiscence and generalized zonular weakness of mild to moderate degree. It also prevents decentration of the optic tilt of the IOL, minimizes fibrosis and collapse of the capsular bag. The original idea was conceived way back in 1991 by T. Hara, who proposed the use of a silicone ring to provide equatorial support and to prevent bag collapse. It was in 1994 that the PMMA ring, which we use today, was finally introduced. Currently, there are multiple variations available in the market. The classical CTR comes in three different sizes. I prefer to use the 11 to 13 mm ring in majority of the eyes, while I prefer to use the 12 to 14 mm ring, which is larger in size, predominantly in longer eyes who have got bigger capsular bags. So when do we use the CTR? The indications, the two most common indications would be in eyes with localized zonular dehiscence of less than 4 clock hours. And second one is generalized mild to moderate zonular weakness. However, the prerequisite for CTR implantation is an intact rhexis. So a rhexis which has gone radial is an automatic contraindication. Similarly, presence of a posterior capsular tear is again a contraindication. Zonular dehiscence more than 4 clock hours are also not ideal for CTR. These capsular bags need to be fixed to the sclera by using a Sionis ring or a capsule tension segment in addition to a CTR. There are two commonly asked questions regarding the CTR. Number one, what stage of the surgery should the CTR be introduced, and how do we insert the CTR? The first question, there has always been debate and discussion regarding the timing of the CTR insertion. We have two options available to us. The first option would be inserting the CTR before the nucleus removal, that is just after completing the rhexis. The second option would be to do it at the end, that is after the nucleus management and cortex removal and before the IOL implantation. Well, each of them have their pros and cons. When we implant CTR before nucleus management, it makes the surgery safer by providing equatorial support all around, and the CTR ensures that the zonular stress is minimized during nucleus manipulation. I prefer earlier introduction of the CTR when the situation demands rather than postponing it. The concern with early implantation has always been predominantly regarding the difficulty in aspirating the cortex, which is entrapped behind the CTR. And the second concern is regarding worsening of the zonular weakness during CTR implantation, which can happen because of faulty technique. The most important message, however, would be that don't delay too much. The zonular apparatus may become too severely compromised during nucleus management before we decide to insert the CTR. Hence, timing is critical, and when in doubt, insert it as early as possible. Now moving on to the insertion techniques. Well, we have got two methodologies by which we can introduce a CTR. The first one is using an injector and second one is by manual.